Hello, everyone. Welcome to the Mobile Social Determinants of Health webinar hosted by H4 Technology and Commonly Well. Today, we will be discussing how to apply mobile social determinants of health to real life encounters and applying that in the real world. I will be one of your presenters. My name is Craig Christensen. I'm co-founder of H4 Technology. We are a behavioral health data warehouse and encounter management system, as well as we have integration and analytic capabilities. And we are the backbone for this solution. Also co-presenting with me is David Whitesock with Commonly Well. David, you want to introduce yourself?
Yeah, thank you, Craig. I'm the founder of Commonly Well. It's a new startup company, and our focus is on improving individual well-being and the pursuit of that, and to drive that through the use of technologies, and in particular, a subjective instrument called the Recovery Capital Index, or in this case, modifying that tool in a way to measure individual social determinants to drive better health at an individual level and in a group level. And all of that is made possible, as Craig said, on the backbone data architecture and systems of the H4 platform.
Great. So just an agenda today, this webinar will demonstrate how a mobile social determinants of health solution can help improve outcomes by identifying and continuously monitoring changing SDOH needs of your patients and clients. Okay, when we are looking at social determinants of health, H4 Technology has a Compass SDOH platform where we're looking at how the whole person cares. So how does social, economic, education, healthcare, behavioral health metrics affect outcomes? And this is something we've been doing for 7-8 years with our state clients. Go ahead with the next slide. Okay, when we're looking at the SDOH needs, it all starts with the data, right? Data flow. So there's patient demographic information that could come from your EMR. We can integrate those data sources. We have assessments built into the Compass SDOH platform. So the RCI, PHQ-9, DLA-20s, those types. Once you get that data in and integrated, then there's standardization, and then we can do predictive risk stratification, predictive analytics, and show the likelihood of remission or ER visits. On the right-hand side there, you see once the assessments are completed, then there's patient identification. So we can do SDOH needs, identifying housing, food insecurity, transportation, and then alerts and notifications can be generated off that data. This enables basically patient engagement, and we'll show you some of that in the demo. With the once you have the SDOH needs identified, for our purposes, we on the behavioral health side for the state-funded behavioral health resources, we actually have those contracts and those providers for the state rolled into our platform. But this on a global scale, people are looking at community resource directories, activation of the specific programs, identifying which programs best for which outcome. And so, the end all be all is being able to continually monitor those patients throughout the SDOH assessments from week to week, month to month, and then detect the changes and anticipate their needs. So like I said, we have a Compass SDOH solution. It's SaaS-based. We're a data management infrastructure. We have over 3,000 users and 2,300 providers and 1.5 million members and growing. This was originally developed as a part of the Nebraska Behavioral Health Division of Behavioral Health need to manage encounter activity for the state-funded behavioral health population. What that eventually grew into is not only integrating with EMRs to get the demographic information, but then also building additional modules for auto authorization of services, workflow if consumers don't hit a minimum standard for services, as well as we build out wait lists, capacity programs, and other modules that interacted with the encounter data management, data warehouse. We've grown that, yeah, with Colorado and other groups now too, and even private groups, private networks. So we have interesting leading assessment features built into that platform. There's standard and custom assessments, individual data points, and the subscales is what we can help analyze. And then all those are tied to an encounter record, so you can get a longitudinal graph over the progress of a patient over time. Once we load that data into the business intelligence tool, then we have scoring and predictive modeling on where the population is heading. What's really exciting is that we had all this for the last 5-6 years in production, and then we met David Whitesock and his RCI vision. And so one of the SDOH tools that we are now partnering on is the RCI. And so from my viewpoint, I saw a lot of assessments out there that, obviously were more of a survey instrument, but didn't go in depth and didn't really address whole person care. And so I'm proud to introduce and co-present with David and have him share the depth and breadth of the RCI and how that's improving outcomes with the clients and consumers he's working with. Take it away, David.
Wonderful. Thanks, Craig. And as Craig said, the RCI is some background, was originally focused on substance use disorder or addiction, but as we went through the development process of creating the instrument, which we'll talk more about in a moment, one thing kept coming clear, and that was much of the outcomes focus around addiction in particular was binary. Was around whether or not an individual was using or not using the drug of their choice. And one thing that we know out of that is that's a well seen outcome point. But what we know is that there are so many other influences. There are so many other factors. Some of those can be leading indicators to whether or not a person's health is going to be turning one way or the other. And some of those can be lagging indicators. And if you get a sense of what those are, you can see this sort of framework or a structure, you kind of get an idea of whether it's your life or my life. We all have these issues. We all have these areas that we know have an influence on our health and well-being. It's not just for one particular condition, but is really translatable to many different conditions. The RCI itself is a tool that is derived from 68 questions or statements. And while that seems like a lot, when you actually look at that framework that we were just looking over, each of those questions is really driving into those various domains and components as you dive down. And so it's one thing to ask whether or not somebody is employed. It's another thing to take that one step further and find out if they're satisfied in their employment, or even one more layer lower, and that is, does that culture of that employment, or does that employer support your well-being, your health and needs, whatever those might be. And those are all factors to just that single one element. So you can start to see how that builds up. The questions and the statements are structured in a way to be easily read and easily understood. Takes less than 10 minutes to complete as you move through the questionnaire. we scored on a 100-point scale. So as you saw, there are those 3 domains, and each of those components, those each have a 100-point scale on themselves, and they all roll up to a total score of 100 or up to 100. And it's raw. It's raw to an individual. It's not weighted, and that's on purpose. And so what we're able to do, and kind of as Craig was talking with sort of the tools in the background, we can start to compare and contrast individuals on their own trend lines and well-beings. But when you put it together in a single population, you don't have to sort of recalculate based upon weighting issues. You've got sort of those raw scores, and you can use various factors to bring that data together. We extend or deliver the RCI in 30-day intervals. So one of the things that we've learned in using this tool, and just to back up a bit, the tool was developed in 2013. It was developed while I was with another organization called Face It Together. And as we rolled that tool out into the peer coaching practice of that organization, we tested various intervals, various frequencies. And over time, what we found is with a lot of behavioral chronic conditions, a lot of those social determinants that we're talking about, those things don't necessarily change overnight. And so 30 days allowed enough time for whether it be clinicians or therapists or coaches or self-managed practice tools, meditation practices, whatever it might be, some other therapy or method for change needed time to sort of work itself out. And 30 days seemed like the right interval to get a really solid representation of a person's change. So when admitted into the system, the workflow fires off so that you would get the RCI instantly in that moment, either to your email or to text, which we'll talk about in a moment, and then every 30 days after for a year. Of course, if need be, we can customize that. You know, as I mentioned, this was a tool that was sort of born out of a necessity, and that necessity in particular was having data to describe the well-being state or recovery of somebody in addiction. Over the years, as we started to build up that evidence, it became pretty clear that in talking to the industry, there really wasn't anything that had been validated in that sense. And when I say validated, meaning go through the rigors and the scrutiny to determine statistically, does the instrument provide or measure exactly what we say it measures, and that is a change in well-being over time relative to a person's condition state, either self-described or potentially diagnosed. And so we did that research. We worked that through with the biostatisticians at Sanford Research in 2017. Our findings led to that conclusion that yes, the RCI measures what we say it measures. We published those peer-reviewed findings in the South Dakota Medicine Journal back in 2018. And that is sort of what's led us into this relationship and partnership now with H4 to take this instrument wider and bring it out to a wider audience to help more people and help organizations better put their arms around what the social determinants really mean and how they can actually integrate into various types of care so that we can maintain and manage people where they happen to be. We can eliminate some of the pressure that might exist in a clinic or on staff in person, and really reach people where they might happen to be. Just on a quick note, sort of when we look at kind of implications of how social determinants, when you eyeball that from above, you have the opportunity to look at each individual score, each individual set of results, and you can inform or personalize care based upon those individual results. And that's really, really important. as we start to move into much more personalized care in this way, matching, building decision models based upon individual results, we can get really complex at that point. But that's just one piece of the puzzle. If you're an organization, a hospital system, a behavioral health agency, whatever it might be, organizationally, when you start to see both the individual results across all of those various components of social determinants, you can then begin to look at your program issues or challenges. Maybe your program was designed to have a focus on housing needs, and you're learning that through those interpersonal relationships that you're building while getting people housing. You're also having an effect somewhere else that you hadn't designed in your program, and it was a natural positive benefit. Well, now you can sort of figure out, okay, how can we do that more intentionally, or just know it's there and not mess it up? Or you can see maybe at an organization level where people on your team might not be meeting certain standards or falling short in a way that could be course corrected in a lot of different ways, or how those longitudinal spread across your organization can give you greater opportunities to describe what your organization does in a community, to your funders, to your stakeholders, whatever that might be, to all of your patient base, of course. And then take that one step higher. When we look at a community, the community is made up of the individuals. And if you can actually see across all of those individuals geographically, socially, behaviorally, environmentally, you can start to understand where in a community there might be deficits, where there are positive trends occurring, maybe because an initiative was put into place. But you could roll that back from start one and say, okay, in this part of the community, we've got this deficit. We didn't know that. We thought we knew that before, but now we actually know it. And we can go right into that community and start designing really effective solutions based upon that data, which means ultimately we can better allocate resources, which is really, I think, what a lot of communities want and need, and especially in this time when we're starting to learn how important it is to have resources not be spread wide for general use, but to really be targeted for specific impact. And I've kind of just sort of was talking into this element here of kind of many uses. Of course, we can think about healthcare. We can think about payers, claims, and what that might have an impact around social determinants. We know that CMS has identified a whole host of ICD-10 and Z codes around social determinants. So that can help, whether it be social service agencies now, find new ways to get to some of these other areas of reimbursement that they probably didn't have access to before because they didn't have a way to measure it. You were probably, performing that thing that could be coded and get reimbursed for. You just didn't have the data to back it up. You might have that ability to do that now. So we could look at social services in a different way. We could look at the criminal justice system and problem-solving courts. Why do certain crimes take place, or why are there trends in certain behaviors that result in crime? We can move upstream in that respect, or move to the point where we have people and divert them out of high cost, high need elements, jails, et cetera, and really build in solutions for reentry and for putting people into a much more positive place going forward. We could talk about employees and leadership programs, for performance. Leader performance is really contingent upon our own personal well-being. So there's implications there. Of course, when we just talked about communities and the social determinants of communities. And so the way that the instrument was structured, with just some minor changes that doesn't take away from its validation, maybe in language, we can really sort of move the instrument in a way that could meet your organization where it's at and its particular needs or audience. Now, with the help and the work with H4, what we really understand and what we're really trying to get after in understanding an individual's social determinants is rely on a particular principle, and that is these are observations that I have in my own life or that patient's life. And it's best that they make those observations for themselves, subjective understanding of their well-being. When invested in their own healthcare, when invested in their own personal outcomes, the response to those questions is going to be highly reliable. And we also know from various research that individuals tend to invest greater in a lot of these personal questions when they can do them at home or do them where they might be. And so mobile technologies like our smartphones, like applications, et cetera, have really increased the opportunity to build in a communication layer between a provider and an individual through questionnaires and various instruments like this, so that you can do that outside of a clinic, which saves time. Having the data come in, it can be structured in a way through notifications so that the care provider is now ready for you when you come in, and we can have a very contextualized conversation, because now we have this two-way engagement happening. It's asynchronous, but it's now moving back and forth as a care flow. And with the reminders out to the mobile device or to a web browser, this is mobile first, and you don't need to log in, you don't need an application. It's a secure link that goes directly to you, connects to your record, and we'll see that in a moment. And it's specific to that particular patient. And so as you can see, it's coming directly to your phone on the left. You can see that link through a text message, and you can click that link and immediately take the survey. And this is what it would look like, as you would see either on your phone browser or on a web browser on a desktop or a laptop. Now imagine if somebody, your particular population doesn't have smartphones or access to email or computers. There's a number of ways that we can move around that. We can, of course, have a workflow that allows you to put it onto an iPad or another computer within your office or agency. Last resort, of course, would be having the individual complete this on paper. And then that information or data could then be manually inputted by your staff or team to get the result in that respect. Why email? Why text message? Why sort of leverage this particular tool in a way so that it is outside the office, seemingly out of your control? Because we're learning a number of things. Obviously, first is that nearly all of the US population has a smartphone, and with a smartphone has a browser. And through that technology, that is instant connectivity. So with the right consent to be able to email or to text onto that device or through to that device, you now know that you can reach most of your patients. We also know that when a text message comes in, it's seen and read within 3 minutes. Pretty quick. What happens on the behavior end after that? That's a different part of the question, which a lot of research is starting to emerge. And that really comes down to the language that's used and the relationship that the person has to that particular message. We are seeing that Medicaid patients are much more likely, and most are much more likely to use text messaging when engaging in their care versus private insured folks. And that's an interesting point, but you want to meet people where they are, and a large part of the population receiving care and a large part of the population needing focus around social determinants are that Medicaid population. And so they're ready to engage. And so we can put this instrument right in the palm of their hands for them to take control, if you will, of that part of their care. When we have that instrument out, and as you can see with 68 questions and a lot of different areas and components, that creates a lot of data for us, creates a lot of data for you, presents a lot of opportunity to really start to see at a certain level where issues or challenges might happen to be. And so we can obviously color code in a red, yellow, green, or a scale from red to green kind of view of what looks good and what doesn't, where things stand out. You can see your population at a summary view through dashboards, and of course those can be standardized to your practice or tailored in a way that you want, or through H4's self-reporting tool, built and designed however you want to answer the questions that you have as they come up. Of course, I'll let if Craig wants to jump in here, to talk a little bit more about how, when we bring that into H4 system and using the Compass tools to really start to drive some of the key elements of the quantification with the quality data to present that to you and your team. Craig, do you want to maybe
Yeah.
dive in here?
Yeah, we have hooked up or embedded within the product is a full functioning business intelligence tool where we have core dashboards for the RCI, but the same token, we don't ever want to hold that data hostage. So you have the ability to go in, and we'll train you on this, to select your own data fields, create your own analysis. Maybe there's a specific RCI subscore, or maybe there's an SDOH need. You want to generate a list. You can easily do that with this report builder and dashboard builder. And so the premise of it is we create the data models for you. You go in and select the data fields you want to use. You can filter on those fields. And then once you get your data set, you can build visualizations. And so there's graphs, pie charts, stack charts, line charts, you name it in there, crosstabs, everything. And so with that report builder or dashboard builder, you can build your own dashboard. You can add the details of the table and connect those two, and then have filters and share your work with other users of the system that are hooked up to your organization. So really powerful tool. And as we keep expanding the capabilities, more and more gets added to this, every quarter.
So we'll take a few minutes and just kind of look at the RCI in the system. One thing that we won't do in this particular demo is drive it to a phone, but you'll kind of see how it all comes together. So bear with me as I bring this up. A pretty simple process with this system, and we really tried to keep it, and Craig can attest to this in particular. We really tried to keep this simple and focused on much of the population that we're engaged with. Obviously, as you start to see some of these terms, encounters, admissions, and discharges, these are terms that you're going to see in your practice. You may see them in your other personal health records or your EMRs, whatever that might be. So a simple layout, very powerful search capabilities. If I want, I can just go to all and search everyone that I happen to have in here. If I wanted to do a quick search by name, I can do that, and I can find say me in here. As we look at this, because it is encounter based, you can see that this one individual is the same individual, but they are, of course, with 3 separate encounters on 3 separate providers. And so, we could have individuals moving between providers. And one thing that, Craig may have mentioned earlier, but, underneath all of this is patient mapping technology. So, of course, individuals can be indexed on their consumer ID and various personal information. And so, within a network, we can make sure that we can continue a longitudinal flow from one provider to the next and not have to be duplicating individual records. So we can accomplish that either through integrations or, as you see here, if I'm just in one system, I could add those as separate instances. If I go into a particular record, then I can see that individual's information. I'm able to see and update their information, their data, however that might be, and their demographics. Now, because we had built this specifically around alcohol or drug addiction and recovery, you see these particular questions. Again, these are all context, and your program may need something else, may need something different. Of course, that can be tailored to you and to your particular program. A lot of this becomes contextual in terms of, how do we then sort of slice and dice that SDOH information. We might have one, let's just say it's employment, and we want to, track off of gender and employment. And if it is an alcohol issue, we can track, or substance use disorder issue, we can track off of a particular substance, and we can see if there are any particular deficits relative to those particular markers. So you can get really granular as you start to engage in individuals or populations as you go forward. As we look at the assessments, we can see those that have been completed. We can see that score. That's the top level score. And we can see when that was completed and view it. And of course, the survey itself is broken up in various parts, and you can see that as you start to move through this. And so that we have the score, we can see this first domain and that particular score, and then this next component, health and wellness. And you can see how these all start to sort of cascade together. And I can scroll through this. So if I'm a care manager or a case manager or a clinician, I can take a very quick look and we can just see, let's just stop at employment. Employment kind of stands out. What's happening here? Knowledge and skills. So I'm just gonna put that into the parking lot for a moment as I start to go through and see maybe where my patient is having some other issues. Okay, family support, social network. All right, so we're seeing employment, connectivity with social systems. Maybe those are related, I don't know, but that's a question I could ask. Now I'm going to start to engage in certain areas. I see a little disconnectedness around cultural relevancy. So now we're starting to piece together a bit of a puzzle. I don't maybe have all the answers, but I'm starting to get some answers, which now means I can really start to figure out if I've got a particular condition. Let's say it's diabetes, and I'm disconnected from my community, disconnected from my family. Diabetes has a lot of behavioral elements to it. And so maybe we start to see some exacerbation on that particular condition because things are not good in other places. And so now we can start to dive in there. And that's how this becomes not just a collection of information, not just a secondary review of data that is kind of put into a black box for a provider, but now becomes part of the conversation around a person's individual care. As we move off of this particular record, and what I will quickly show, we'll go down to the dashboards and the data in a moment. But if I come back and just to add somebody, I'll show you how relatively quick that is. If I was to say, let's search to see if Jane Smith is in here. She's our patient. We don't have a Jane Smith, so we're going to create Jane. We'll add her birth date. That'll be today's date. And we can leave that blank for a minute. We can choose from any of our service providers, the unit that it's associated with, and this is the service. And we've got Jane created. We'll add her information here, which I won't do now, but once we add an email address, once we add a phone number, this will then take us and allow us, actually I just might do that. I'll just, we'll put my number in. we'll save that. As you'll see, some of this information will be required for us to move forward. And we'll just do this relatively quickly. I'll decline these. Of course, these can be delivered in various ways that might work within your particular workflow. We'll say yes for that. We'll just pick one. Let's say today was the last date of use. Again, this does not impact the scoring of the RCI. It just happens to, it can give us a correlative data point. Save that. We admit just to kind of work ourselves through this workflow. Make sure all of that's there. Our demo environment just lets us know that this will send and speed up the workflow over 3 months across 3 days. In the live environment, of course, that's based upon your workflow, but otherwise it would be every 30 days for a year. Once we submit that, it then goes out and that individual would then receive the email with the link to the survey and also a text message to complete the survey. In the same place, we don't have to go anywhere else. I don't have to log into any other system. We can move into the reporting mechanisms and the self-reporting tools. If we, depending upon how we want to set this up, but we could imagine we could do this for individuals or at a larger scale. We could see this person's scores over time. You can imagine that we could do this against a time bound. So this could be a baseline score, then 30 days, 60 days, 90 days, et cetera. Or we could just see it across a calendar over time. We can, it's not pulling up here, but we can pull we can see the raw data below. I'll show you what that looks like here in just a moment. We can go into then, of course, the dashboard. And as Craig talked about, this could be designed or structured in any way that fits your organization. In this respect, just as an example, we could break this down by domains, and we can see at a population level sort of how are these scores being represented against the population, or in this case, against time. That might not be the right representation, but it's just a way to look at it. Maybe we've got goals that we want to set, and we could set a target here of where we want our organization to be with our population, and so we can see this at a glance. So that's really the nuts and bolts of the system, of seeing the data as it comes in, being able to move very quickly from the place where it comes in to where we can actually see it in terms of information, and then act upon it in that particular respect. So with that, Craig, I'll hand it back to you to see if you have any questions.
Yeah, just want to thank everyone for attending the webinar. We will be sending out the slide as well as this webinar recording to everyone. And I just want to reiterate, when we're working with providers, I think it's at the start, this is a turnkey SaaS solution. Implementation time can be as little as 2 weeks. And we also have it scalable. So, smaller providers can start all the way up to larger agencies or network of agencies. And so we truly have a scalable, solution to fit any and all your needs. And if you'd like more information, obviously reach out to myself, Craig Christensen at h4technology.com. That's my cell phone, 402-598-6561. And I work almost daily with David now on this platform. So I want to thank you for participating, and look forward to talking to you soon. Thank you.